Welcome back to AIC Science Into Practice, the podcast where hand sanitizer and humor share equal billing. Honestly, we're scrubbing in for laughs and for learning.
Today, we're spotlighting Alabama's Regional Center for Infection Prevention and Control, or ARC-IPC. Because when it comes to outbreaks, sweet tea won't fix everything, though it might help with the paperwork.
Nah, sweet tea fixes everything. Hey, we're joined today by two powerhouses from UAB.
First up, Dr. Matthew Fifolt. He's an associate professor in the Department of Health Policy and Organization at UAB's School of Public Health. He directs the Survey Research Unit, which means when Alabama wants to know what people are thinking, he's the one holding the megaphone. He's also led statewide surveillance projects like the Behavioral Risk Factor Surveillance System and National Core Indicators. And just to flex, he's published over 100 peer-reviewed articles.
Oh, wow. Well, and alongside him, we've got Dr. Lisa McCormick. She's the Senior Associate Dean for Academics and Practice at UAB's School of Public Health, a professor, seasoned leader in public health preparedness and response, and she's led strike teams in long-term care, secured over $75 million in funding, and authored more than 50 publications. So basically, if Alabama were a patient, Lisa would be the IP at the bedside with a care plan, a grant, probably some snacks too, right? So let's dive on into the article. They've got an article called A Review of Initial and Ongoing Training Needs through the Alabama Regional Center for Infection Prevention and Control. So let's get right into it, guys. Welcome to the show. What was the spark that made Alabama say, we need an infection prevention center and we need it yesterday?
I'll take that one. Well, thinking back to 2021, it really was the perfect storm during the COVID-19 pandemic. And we really realized here in Alabama that our healthcare facilities, especially our rural hospitals and long-term care facilities, were really struggling to maintain their infection prevention and control programs. Many facilities faced high staff turnover rates, so they constantly struggled to keep everyone trained and up to date on the latest guidance and requirements. And you can probably remember back to the beginning of the COVID-19 pandemic, those guidelines were changing rapidly as we learned more about the virus. And early on in the pandemic, resources were really limited. As PPE and other supplies became available, we desperately needed a mechanism to teach basic IPC fundamentals like proper PPE donning and doffing. And that's really when Alabama realized that we couldn't wait any longer. We needed a centralized expertise and training capacity in the state.
So you structured your needs assessment around the CIC exam domains. How did you decide this was the most appropriate framework? And were there any gaps that didn't fully capture what you were looking for?
Yeah, so this is Matt, and I'll take this question. When we conducted our initial needs assessment, there was a great deal of uncertainty, as Lisa just mentioned, as well as disinformation and misinformation about the COVID-19 pandemic. Therefore, most of the topics that the ARC-IPC covered during the first year was on topics related to COVID-19. Some of the topics included prevention and mitigation strategies, basics of sterilization, masks, and PPE. We designed our needs assessment around the 8 priority CIC domains so that we were able to target training and technical assistance to any group. And we were contacted by just a wide variety of audiences, anything from hospitals and healthcare facilities to schools, daycare centers, and long-term care facilities. So we really needed a framework to organize topics and to identify experts that were most qualified to address these topics. So the framework provided both a structure and flexibility for the ARC-IPC.
And it's a great approach because you guys really were when I say all over the place, you were looking at long-term care versus acute care versus K through 12. So were there any surprising differences in the training needs across those stakeholder groups?
I don't know if there were any huge surprises. There were definitely differences, especially for people who work more in clinical versus non-clinical environments. when you're talking about people who were working in clinical environments, things like antibiotic stewardship kept coming up. And then, of course, basic topics like hand hygiene and just basically how do I document things within my infection prevention and control program and what's reportable versus non-reportable. In non-clinical environments, it was really about vaccine hesitancy, mis and disinformation. How do I talk to parents about X, and how do I deal with situations like this? And how do I teach hand hygiene to the people who work in my daycare facility? So those were the kind of things that we saw. And, so there were commonalities between clinical and non-clinical environments. Hand hygiene is one of those.
Exactly. And it's a huge reminder that infection prevention is not only very simple and basic, but also extremely broad with a huge umbrella. So many topics in there.
I'm sorry to interrupt. I would add to that one of the consistent topics across populations was sterilization and, environmental services. How do we ensure that our environments are safe? And again, that's going to vary between clinical and non-clinical environments. But the basic question was, how do we ensure that we can reopen and keep everyone healthy?
Yeah. And as Nikki mentioned, big umbrella. So how did you prioritize among so many needs, PPE use, outbreak reporting, antimicrobial stewardship, when planning those first trainings? It sounds like a huge buffet of IPC.
Yeah. And it was quite overwhelming, but the answer to that was actually relatively simple. Focus groups. We work with different stakeholder partners like the Alabama Hospital Association, the Nursing Home Association, the Assisted Living Association, our local APIC chapters. And if you don't know what APIC is, that's the Association for Professionals in Infection Control and Epidemiology. We work with our Department of Ed to get to our school nurses. We work with child care resources to get to child care facilities. And we did focus groups. We had those different professional organizations help us pull people together that were in the know so that we could go through the needs that we identified to help prioritize what we should expend our limited resources on moving forward. Where were we going to get the most bang for our buck and fulfill as many of these needs as possible that we could in as quick of a time period as possible? And another thing we covered within these focus groups is how do we best reach these different target audiences? Because again, Alabama, we have a lot of rural areas and it's not always practical to bring people to one location. So how are we going to do that?
Wow, that so complicated sound much simpler, but I'm sure it wasn't as easy as you make it sound.
Yeah, and it's just so robust. I mean, there's so much to cover. And you talked about, the challenges in reaching rural hospitals and long-term care facility, and some of those places are at risk of closure. So tell us about some of those challenges. What were some of the biggest challenges in reaching them?
Yeah, so Alabama is a non-Medicaid expansion state, and as such, some of our rural hospitals are struggling to remain open, and our long-term care facilities, are always short-staffed, and they don't necessarily have enough time or staff for someone to travel, say, to Birmingham or Montgomery to attend a training. So what we did is through our long-term care strike team, we started doing regional trainings around the state, kind of focusing on different geographic areas around the state. We started doing in-service trainings within some of these facilities. We started doing online trainings and webinars, things that people could do when they had a 30-minute break versus having to, schedule 2 hours out of out of their rotation. So we tried to be as flexible as we could with the different modalities that we chose and tried to do even covering the same topics via multiple modalities so that as many people could be exposed to the content as possible.
If I could just take a moment, I'd really like to brag on Lisa and the ARC-IPC.
Seems very braggable, so
Well,
it's going to be very hard.
I think that she underplays the magnitude of the ARC-IPC. First of all, to stand up a center in such a quick period is remarkable. It takes a great deal of effort to create a center at the university, and she and the dean really pushed it through based on the needs of the state. So overcoming that first hurdle is significant. Two, the steering committee that she assembled comprised experts from public health and infectious disease and the hospital and healthcare systems, and all of these partners really coming together to address the varied needs across the state. And those individuals connected ARC-IPC to experts in the various topics that we've discussed. So it really became a network across the state serving the IPC needs of the various populations.
Yeah, and let me go ahead and hop in then now and say, give you my condolences, because I understand that the current administration has cut funding for that, and that's bad for patient safety. So bad for patient safety and bad for Alabama. I'm really sorry to hear that. All of that extensive work and networking that you have done and all of those connections you've put together seems all for naught, but it's not. You've done great work.
Yeah. And I will say we were very disappointed. Our funding was part of the ELC funding, the epidemiology and laboratory capacity funding from CDC to our state health department. So that was terminated earlier this year. But I will say our health department is really, trying to find additional funding, and they're really wanting to support infection preventionists in all of these different types of facilities. And, I will say this too. I do believe through the limited time that we had this funding, the few years that we had this funding, we were able to substantially increase infection prevention and control capacity in the state by getting people certifications in infection control, prep courses, and helping people get their certifications by holding infection prevention boot camps where we brought together infection preventionists from hospitals around the state together so that people were able to form networks so that infection preventionists at a rural hospital didn't feel like they were alone or the only one dealing with a certain issue. Now they know that there are infection preventionists at many other types of facilities that they can call upon to get assistance.
Well, that's very positive.
And I mean,
I try to be.
It sounds like your health department sees the value in the accomplishments and the improvements that have occurred as a result of this program. And so it's a little bit like from CDC and the administration, like, I can't see it from my house, like, because it's not happening in my backyard, maybe I don't care so much, right? Whereas we really need to care because eventually this is happening across our country. It's impacting numerous patients and healthcare workers. And over that period of time that ARC was in place and was doing this critical work, those hospitals and schools and long-term care facilities, all of the facilities that you've been able to touch have made improvements, and it wouldn't have happened without this program. So I just think it's great that you're still looking for and your health department is seeking support to keep this going?
Well,
Yeah.
healthcare workers are nothing if not resourceful, right?
Right. And I will say that I do think it was a bit short-sighted on the administration's end to terminate this funding because they don't realize, they get this idea that, oh, we've done that, it's done, now it's over. But there is a lot of turnover in the facilities for which we serve. There's a lot of staffing turnover in long-term care facilities, in rural hospitals in our state. And it's not a one and done type thing. This has to be a
Right.
constant effort to keep our infection prevention and control capacity in the state. And it's not just going to be done in 4 years. And it's going to be a continuing battle.
And not to mention there's always, sorry, not to mention there's always emerging MDROs and other threats too. So
Yes.
sorry, Matt.
That's right. No, I was just going to say that's exactly the point. Jessica, it is in their backyard. They just don't realize it. Infectious
Exactly
diseases
right.
don't recognize borders. So what's happening in Alabama absolutely affects what's happening elsewhere. So as Lisa suggested, it does seem short-sighted to put this problem away when it's still an evolving issue. So emerging and re-emerging infectious diseases that occur in Alabama are going to cross state borders. And what may not feel like your problem today is definitely going to be your problem tomorrow. So it's really a trade-off.
And where will the blame be placed then? Right?
Well, we are a reactive society. We tend to put funding where, once a disaster happens. And I say that because I'm public health preparedness and response expertise. But that is true. We're a very reactive society, and we tend to put money in response, but not so much in prevention and mitigation.
Which is in our name, infection prevention and control.
Right. So we sort of went off on a very important tangent, but getting back to the different modalities of how you reached all of the different folks, how did you then adapt the training delivery to fit the different audiences? So you had infection preventionists you were trying to reach, school nurses, environmental services staff. How did you then adapt to make sure that you were providing the right information in the right modality? How did that all work?
That's a good question, because I am not an expert in infection prevention and control, and never would I tout myself to be one. But I can connect with the people who are the experts and who work in child care facilities and are the experts in child care facilities, are that work with environmental staff in hospitals and is the expert, or is an infectious disease doctor and is the expert. So I think the key for our center was being able to link to the experts and bring the right people in to do the trainings around the needs that we identified. That was really the key to it all, is just being able to link in, to have the resources to be able to get the right people to come in and do those trainings.
And I would add that, again, to Lisa's point, the ARC IPC was incredibly nimble in terms of offering multiple strategies to address topics for multiple populations. So if an infection preventionist, for example, couldn't commit 2 days to training, perhaps they had a half day. Or if they couldn't do a half day, perhaps they had 2 hours for a podcast or some kind of webinar or self-paced activities. So I think that as the ARC IPC evolved, the communication strategies and training strategies evolved with it.
Definitely.
That's great.
Yeah, it's not a one size fits all. I mean, you really have to be adaptable to everything.
Right.
Beyond satisfaction and knowledge gain, have you been able to measure whether the trainings translated into practice changes or improved outcomes at the facility level?
one thing we were able to do, and then I'll pass it off to Matt, in partnership with our hospital association, we held some infection prevention boot camps and the CIC prep courses. So we were able to monitor the people that completed those to see how many of them went on to get their certification in infection control. Through the center, I was actually able to pay for people to do the CIC test, whereas that was a barrier for many of our infection preventionists. They just couldn't afford to take this expense on themselves. So we were able to see specific things like that, the number of IPs that were getting their certification in infection control. Matt, I don't know if you have any other examples.
Yeah, I was just going to add that in addition to knowledge gain and satisfaction, we did ask questions about intent to use or next steps so that individuals could identify specifically how they intended to implement these strategies. So, I mean, that really moves beyond knowledge and satisfaction to application. And individuals were able to commit to an idea that they learned during training that they could implement in their facility immediately. And
that's such a gift, really, because like you said, a lot of IPs can't afford to take the CIC test, and being able to be given that. And like you said, Matt, I want you to continue because that's a really good point, being able to implement all this stuff that they might not have been able to do.
Yeah, even proper hand hygiene practices within their facilities. One of the other things we were able to do was to buy every long-term care facility, every assisted living facility, and every hospital in the state of Alabama glow germ kits so that, so we would do a train the trainer with them. They would take a glow germ kit back to their facility and then do hand hygiene training, which could prevent up to 40% of hospital-associated infections. So just really important things like that, rural hospitals and long-term care facilities otherwise wouldn't have had the funding to do, even to buy glow germ kits is not in their budget. So
that's the exact example I wanted to share from one of the trainings. I was looking through comments and next steps that individuals wrote down. And one of probably the most meaningful one that I saw was a participant who attended one of the boot camp training sessions. And in response to next step, the individual said, "I really want to utilize glow germ to hammer home the why of hand washing among our staff." So I think that in addition I think maybe the most important aspect of that training in particular was the hands-on aspect of it. They could see how contamination can easily spread and how hand washing and just basic sanitizing can make a huge difference in facilities. So they experienced it for themselves, and then using the glow germ kits that ARC IPC provided, they could then train their staff and demonstrate the power of basic hand hygiene.
Yeah, and environmental cleaning. We taught them how to use glow germ in environmental cleaning as well.
Right.
So, yeah.
I always loved the glow germ kits. They were a lot of fun.
They are fun. Yeah. Yeah. There's so many significant long-term impacts of the ARC IPC. What do you think has been the most significant long-term impact so far?
I think, again, helping infection preventionists around the state build a network amongst each other so that they don't feel alone in the job, and that as new IPs come on, hopefully they're able to connect with these other IPs that were able to attend some of the trainings and get some advice and training from those IPs. So I think that is really important. I think having more infection preventionists out there that have the certification in infection and control is important. And so hopefully that that will have an effect and they'll stay in their jobs for a while. And, and just really having more daycares, K through 12 schools, senior centers, and others really thinking about how do we prevent the spread of infectious disease in our facilities as well? And what are some basic things that we can do to prevent our clients and ourselves from becoming ill. So I think that's been really important. It really sparked the conversation about infection prevention and control across multiple stakeholders. And I think the conversation is still going on. And I think our local APIC chapters are thinking about how do we reach out to these other groups and get them involved, that maybe this isn't just a Department of Public Health issue. This is all of our issues. And how do we move forward in the
public
future?
health is everybody's health.
Yes.
Yeah.
Exactly.
Public health is everybody's health. The community, it belongs to everybody. So tell me, if another state wanted to replicate the ARC IPC model, what advice would you give them at the outset? What's your starter pack?
I think the starter pack is pulling together the right steering committee, making sure that you have the experts on your steering committee, because they're the ones that really provided the guidance to kind of steer the ship, right? And to tell us when, we could do something better, and to tell us we're missing a certain stakeholder group, or to tell us when, there is a really important emerging topic that's coming about that y'all need to address. That is how we kind of charted our course, is through that direction.
Who was on your steering committee?
We had, of course, all of our public health leaders in infection. In Alabama, we call it Infectious Disease and Outbreaks Division. We had infectious disease docs. We had experts in long-term care and assisted living. We had experts in child care. We had school nurses that represented, that work in our K through 12 schools. And many, many others. We had people who had been working in infection prevention and control in hospitals for years. We had people who represented APEC. We had people who worked in children's hospitals, people who worked in rural hospitals, people who worked in well-resourced hospitals, and those that weren't so well-resourced. So we really tried to cover the gamut and to try to figure out, when a need came about, who was the expert that we needed to reach out to help us develop the training. And usually if someone on our steering committee didn't know who the expert was, they knew someone who knew someone that knew who the expert was. So I think, and I'm sure I'm forgetting some of the folks that were on our steering committee, and I apologize to them for that, but those are the kinds of people.
And I would say that while those groups might meet in smaller cohorts, that bringing them into the larger conversation brought about some incredible synergy. In addition to the steering committee, again, I can't overestimate the valuable contributions of Lisa and her team, because while the steering committee provided guidance and support, the ARC IPC was successful because it had a champion, it had boots on the ground, it had people who could implement activities really at a moment's notice. And I mean, it takes a great deal of person power to drive that initiative. And I would say Lisa spent a tremendous amount of time guiding the ARC IPC towards its success. So I think if another state wanted to replicate it, it would need to find someone like Lisa. We're not going to give her away, or please don't recruit her away, but she was really more than, well, I mean, she was the driver of the ARC IPC.
Lisa, do you like horses and bourbon?
Oh, yes.
Okay. Just saying, Kentucky's fun.
Yes.
Nikki's like, you'll be receiving a job offer by the end of day today.
Yeah.
Sorry, Dr. Fifolt.
Well, if she keeps me with her,
Guys are
that's
funny.
fine.
So
Yeah.
thinking about this from a practical angle, when we talked about resources like time and staff are often short, what is the one training that should never be skipped? Like the broccoli of IPC, you may not crave it, but you have to have it.
Well, I think our IPC boot camps, and these were annual boot camps that we did that really went through the basics of infection prevention and control. And then, of course, our CIC prep courses. I think those are the two things. And we did boot camps that were just focused for IPCs working in hospitals. Then we did boot camps that were just focused for infection preventionists that work in long-term care, because there is some differences, but those were really the meat, of the topics that we provided, and again allowed those infection preventionists then to build networks with other IPs and facilities similar to their own. So I think, and if anybody would like a copy of the agendas for which we used, every year the topics would change a little bit based on kind of hot topics, current topics in infection prevention and control. But I would be glad to share the agendas from the infection prevention and control boot camps to anyone who would ask. We can give my email at the end if y'all want.
Well, I may be leading us down a path that I can't back up, but I would say one of the most invaluable resources, at least during the run of ARC-IPC, was the enduring materials that we had online. So as Lisa had mentioned, staff turnover quite a bit in long-term care facilities and other types of facilities. So being able to provide just-in-time training through web-based resources is pretty indispensable to ongoing training and support.
Yeah, that's a lot. I mean, you've trained over 70,000 participants. I mean, that's a stadium. That's a football stadium. So, well, let's lighten it up. What's one story that sticks with you from all those trainings? And it's a bonus point if it's something that makes us chuckle.
Oh, I have learned that people are very concerned about their hairdos. So when it comes to PPE donning and doffing, they're a little hesitant sometimes, but you kind of have to lighten the load for them and let them know that, your hair is going to survive. But, if you learn how to don and doff PPE correctly, then that can help protect not only you, but your patients as well. So
that's right.
Yeah.
You're beautiful any way you are.
You're beautiful any way you are. It
Or
doesn't
maybe
matter.
you need to come up with a new type of hairspray that really helps. That's where your retirement's coming in. That's how we're going to fund. That's how we're going to fund it. You're going to come up with a hairspray that helps preserve the PPE hairstyle.
Yeah, and when we were doing N95 fit, we did a lot of N95 fit testing in facilities and help people kind of stay up on their fit testing requirements. And, and there's all these funny things that people have to do once they don their mask and they're being exposed to the challenge agent, but basically nodding their head left and right, up and down, and, making funny faces and things like that. And I just have to thank everyone who were so patient with us, because we fit tested thousands of people across long-term care facilities around the state. And for some people, they didn't quite understand why they were having to do it, but they really stuck in. And I think that it really has, again, gone a long way in making people understand the importance of wearing PPE, the fit of that PPE, and how it can not only protect them, but their patients.
And I'm sorry again to jump in, but that was such an issue early on and continues to be an issue of people wearing masks, but not wearing them correctly. So that fit testing is so important. And I would imagine, Lisa, when you and others were traveling across the state to do fit testing, that more often than not, you probably saw people wearing masks incorrectly.
Or not having the correct size or type to fit their face. So I think, it really, the COVID pandemic really highlighted that, especially in long-term care facilities where at the beginning of the pandemic, they didn't even have N95 sprayers, a lot of them. So now that is something that they hopefully regularly have on hand.
Yeah. Unfortunately, good intentions aren't enough. Proper fit is critical.
Absolutely. Okay, myth or fact? IPC training is only for infection preventionists.
Yeah, I'm going to take that one. That's absolutely a myth. Data from the ARC IPC demonstrates that frontline staff, environmental services staff, and even school nurses are critical IPC partners. So IPC, as Nikki mentioned earlier, is everyone's responsibility. It's everyone's business.
Mm-hmm. The more the merrier.
The more the merrier.
Yeah. Well, here's your charge nurse huddle nugget. Staff sustained training plus certified IPs equals stronger defenses against outbreaks. So stick that on a Post-it. All right, guys. Huge thanks to Dr. Fifolt and Dr. McCormick for showing us how Alabama is building IPC muscle.
Thank you for having us. This has been great.
Absolutely.
Thank you.
Absolutely. So, Lisa, how are we going to get in touch with you if we've got questions?
Feel free to email me. My email address is lmccormick@uab.edu.
And so let me spell that real quick. That's LMCCORMICK plus all the other stuff she said.
And thanks to our listeners for listening. Subscribe, share with your favorite IP, and remember, the only thing we spread here is knowledge. Well, knowledge and maybe a few awkward jokes.
We're full of them. All right, guys. That's a wrap. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science Into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AIC Science Into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the AIC Center of Research, Practice, and Innovation, and Jean Brandt at AIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, AIC That's AJIC scienceintopractice.org.